Hello, this is going to be take 3 of this lecture about caring for patients with urinary tract disorders. So we're going to talk about urinary tract infections, causes, symptoms, treatment, the same for kidney stones, cancer of the bladder, cancer of the kidney. We're going to talk about some diversions, urinary diversions, ileal conduit or reservoir. What's going on with clients that have diabetic nephropathy, nephrosclerosis, hydronephrosis, and glomerulonephritis. Symptoms of patients with acute kidney injury as well as chronic kidney disease. And we're going to talk about nursing care for clients with acute kidney injury, chronic kidney disease, those that have vascular access sites for dialysis, and patients that are on peritoneal dialysis. So let's start off by talking about urinary tract infections, where an invasion of the urinary system by bacteria that occurs in women greater than men due to the shorter urethra in women than in men. And as we get older, you'll see men increased incidence of UTIs due to enlarged prostate, and women due to the declining estrogen. We have to divide the urinary tract infections up into upper and lower, and we'll talk about both. With lower urinary tract infections, we're talking about urethritis, prostatitis, cystitis. Cystitis would be bladder. And upper urinary tract infections include pyelonephritis, ureteritis, which can lead to more complications. So if we look at some predisposing factors for urinary tract infections, including stasis of the urine or incomplete emptying of the bladder. If a person's not urinating enough, there's over-distension, and as a result, decreases the blood supply to the wall of the bladder, which keeps white blood cells from fighting off anything that's entered into the bladder. So, and then when you have stasis of urine, it just provides a great place for bacteria to increase in numbers. Contamination of the perineal or urethral area from feces generally is a big culprit from improper cleansing. Could occur from sexual intercourse where bacteria are entered into the urinary meatus, or an infection in the area such as vaginitis, epididymitis, or prostatitis can all contribute to contamination of that perineal or urethral area. From instrumentation can increase the risk for a urinary tract infection, example during testing or studies, or insertion of a urinary catheter increases risk. Reflux of urine is essentially when the urine doesn't go one way from the kidney, ureter, bladder, urethra, and out, where you can have reflux where it goes the opposite direction. So it could be that it occurs when due to a malformation, so it's been there since birth, or it could be sometimes as a result of previous infections. Somebody that's had previous urinary tract infections is at increased risk. There could be colonization and puts them at increased risk for recurrent UTIs. Women that are pregnant are at increased risk of urinary tract infections. Asymptomatic bacteriuria, sorry about that, normally is untreated, but in women that are pregnant, 40 to 50% of them will develop pyelonephritis. So later on in the pregnancy, second and third trimester is an increased risk for this. Aging, as we get older, as we already mentioned, the decrease in estrogen in females and enlarged prostate in males, and urinary tract infections and its relationship to sepsis. Big contributing factor is urinary tract infections. So some signs and symptoms of urinary tract infection include difficulty urinating, dysuria, or painful urination. Urgency, frequency could be incontinence, in addition to a cloudy, possibly foul-smelling urine, all indicative of a urinary tract infection. In atypical symptoms, could be a change in cognitive functioning in older clients. Anybody that has an indwelling catheter has a change in mental status and a fever meets criteria for urinary tract infection. So we need to be alert. So we need to know baselines. Okay, so urethritis is a type of urinary tract infection where we have inflammation of the urethra. It could be from a bacterial infection or trauma or an STI. So even somebody that's doing self-catheterization can be at increased risk of urethritis. So gonorrhea and chlamydia infection in males can cause urethritis. Symptoms will include frequency, urgency, dysuria, and some men will have penile discharge. Treat the cause. If it's because of irritation, reduce the irritation. Antibiotic is prescribed when it's bacterial. Pyridium is a medication that's an analgesic, and it's given to treat the painful urination. And patient teaching includes that it's going to turn the urine orange. Cystitis is an inflammation or infection of the bladder wall. Most your bladder infections are from E. coli. So improper cleaning from the perineal area up the urethra into the bladder. Symptoms: dysuria, frequency, urgency, and a cloudy urine. We call urinary cystitis uncomplicated or complicated. If you think of complicated as ones that may have occurred in somebody that gets them frequently, or in somebody that is hospitalized, that would be considered a complicated urinary tract infection. And culture and sensitivity is done because you want to make sure that you're treating the right culprit. Because that you have resistant organisms, especially with hospital-acquired infections, you want to make sure you're treating it accurately. For uncomplicated cystitis, Bactrim is often used, or macrodantin. Ciprofloxacin Cipro is used to treat complicated cystitis, often if still effective on CNS. With anybody that's taking antibiotics, making sure that they take the whole dose and drink lots of fluids. Pyelonephritis is an infection of the kidney. So it could be in one or both kidneys, infection of the pelvis tubules. It usually is from a lower tract infection that goes up the urethra to the bladder and then up. So risk factors include surgery, a lymph infection, stasis of urine, or decreased immunity. That'd be one type of pyelonephritis. Acute pyelonephritis begins in the medulla and then spreads to the cortex. Pyelonephritis. So, pathophysiologically, you'll see abscesses throughout the kidney and an enlargement of the kidney. You might see that bacteria is spreading from the bloodstream to the kidney when blood is being filtered in the kidney. Um, uh, Urosepsis is when there is a urinary tract infection that's significant, and then you have the whole body affected. It is a whole body inflammatory response. It's very serious condition and can be fatal. Signs of pyelonephritis include fatigue, urgency, frequency, dysuria, flank pain, fever, and chills. And you might have costovertebral angle tenderness. So it's where the rib and the vertebrae meet. The lower rib and the vertebrae meet. Might be tender back there. So data collection for urinary tract infection includes asking questions, or do they have any pain, to ask about frequency, ask about flank pain, fever, chills, malaise, any change in pattern, examine the urine for presence of blood, or the clarity will be cloudy, and any foul odor. If they have an increased risk, and we're going to also we're going to ask about any increased risk factors and get urinalysis and culture and sensitivity results. So nursing diagnoses for urinary tract infection include acute pain, impaired urinary elimination, risk for injury, and deficient knowledge. Starting with acute pain, you should see with antibiotic use, you'll see a decrease in pain as the inflammation and infection dissipates. But you may need also to give antispasmodics or analgesics to reduce pain. Encourage fluids. Apply warmth possibly to the suprapubic area. That may help. Encourage emptying of the bladder. And cranberry juice or cranberry capsules, and the evidence-based practice listed on 838 is a good explanation of how that works. It prevents the bacteria from sticking to the wall. Take all medications as prescribed, avoid irritants, empty the bladder when you have a sense to void, and avoid irritants such as bubble bath or scented wipes or toilet paper. Risk impaired urinary elimination. We want to make sure we have 30 mLs, at least 30 mLs an hour. So we're going to monitor INO, administer antibiotics, push fluids, encourage a woman to void after sexual intercourse. Recognizing signs and symptoms of a urinary tract infection. Once you have one, you generally know what it feels like, and somebody that gets them frequently is very acutely aware of what they are. So they should be reported to make sure that proper treatment is delivered. Risk for injury related to sepsis, kidney disease, or kidney injury, making sure that the medications are taken as prescribed to prevent complications. Monitor INO. Monitor signs and symptoms of bacteremia or bacteriuria for worsening. Explain the need for follow-up urine culture when somebody has recurrent symptoms after treatment. They might do a repeat urinary culture and sensitivity. Encourage hydration and teach signs of urinary tract infections. And with deficient knowledge, we always want to know the starting off point. What do they know? And give them information about their meds, etc. Signs and symptoms. Nursing care includes watching signs and symptoms for worsening, watching INO, administering meds for pain control, as well as the antimicrobials, and prevention, fluids, emptying when urge occurs, proper cleansing techniques are all things that can contribute to prevention of a urinary tract infection. All right, the next thing we'll talk about is urologic obstructions. So when there's a blockage somewhere, then you could have obstruction of urine flow, which is always going to be a problem, because when urine backs up, it can destroy the kidney tissue. So it could be because of strictures in the urethra, possibly from scarring from procedures, from catheterization or cystoscopies or something. Or it could be renal calculi, which are the kidney stones. Generally, they're hard. They can be small and even doesn't even know that you had one. Another name for kidney stones is nephrolithiasis. So the picture that's on this slide is on, on page 842, and it's just showing that you can have stones in any part of that urinary tract, from the kidneys to the urethra. So if you look at the kidney, you could have small ones, or you could have a staghorn stone, which is quite large, that kind of fits in, molds into under the papilla of the renal pyramid. You could have them anywhere from the pelvis into the ureter and bladder stone, urethral stone. And you see on the right-hand side where you have a ureteral stone that's blocking urine flowing to the bladder, and therefore urine backs up, and you see then the enlargement in the of the pelvis in the kidney. So what's happening is that there are urinary salts that settle out and crystallize and cause stones. Calcium oxalate is the most common type, but you'll see on the bottom of page 841 all the different types of stones. In addition, you see like the features of that stone and then some common causes. So if you look at that box on 841, you see calcium oxalate. That causes include excessive calcium, somebody that has hyperparathyroidism or Cushing's disease, or tumors of the breast or lung. And also in this chart, to the far right, you have interventions for each of those. So for the most common one, calcium oxalate, forcing fluids but restricting protein and sodium in the diet. Hydrochlorothiazide may be administered. Treat that hyperparathyroidism if that's the cause, and administer Calcibind, which will bind the calcium in food in the GI system and prevent stones that way. So it could be somebody can be at risk for kidney stones because of heredity, a family history of stones. State of chronic dehydration, so somebody that has constant chronic concentrated urine. Infection can be the impetus for a renal stone. Infectious material then surrounds with some of these other deposits. Immobility, dietary, and in general, men have more kidney stones than women. So under diet, a diet that's high in sodium or animal protein will increase the amount of calcium in the urine. So that could be a contributing factor. So the problem or complication, it could be the hydronephrosis, where there's fluid backed up into the kidney, and we'll talk about that later. Some signs of renal calculi include flank pain, renal colic, dysuria, costovertebral tenderness, blood in the urine, frequency, urgency, enuresis, incontinence at night, and GI upset are all signs. It could be excruciating pain. And it could be a reason, it's often a reason why people will seek assistance at an emergency department is a renal calculi. Diagnosis of kidney stones occurs with abdominal x-ray or IVP, renal ultrasound, or urinalysis. Treatment includes small stones may pass on their own. That's without any intervention. Other times, if it's bigger, they might have to do a lithotripsy, which we'll see on the next page. Fluids are encouraged to help flush out the stones. Analgesics will be given, ibuprofen or Tylenol, possibly something stronger. May give thiazide diuretics. Somebody that has significant renal colic might be admitted on IV fluids to help the stones flush out. And one of the things that we do is strain the urine. It looks like a colander that all urine goes through to catch the stone that's passed and to have that analyzed for what is it composed of. One, to prevent reoccurrence. So this is a picture of the extra outside of the body, extracorporeal shockwave lithotripsy to break the stone into smaller pieces so it can be eliminated. It may require other interventions where they will need to perform a procedure to get the stone. It could be done during a cystoscopy, where they'll go in and take the stone out, or a cystolithoplaxy, which instrument will break up the stone that's after the instrument is inserted into the urethra. A cystotomy, and a ureterolithotomy are other procedures that may be done, and a nephrolithotomy is when a scope is inserted through the skin to the kidney to help break up the stone. As a result of the nephrolithotomy, a nephrostomy tube will be left to help break the stone that was broken up into smaller pieces leave the body versus going through the rest of the urinary system and potentially causing a blockage somewhere else. So renal calculi or kidney stone prevention includes diet, as well as hydration and exercise, because immobility and decreased fluids contribute. So dietary recommendations: low purine, low oxalate, push fluids. And complications, as we mentioned, of renal calculi include urinary tract infections from stasis as well as hydronephrosis. Nursing diagnoses of acute pain, risk for infection, and deficient knowledge are some. When a person has kidney stones, the pain will generally, as I mentioned, will be a big reason why people seek help. Recognizing pain and a proper assessment is necessary. So it's going to include when we're working with people that have kidney stones is collecting data. They have a history. Have they had it before? That renal colic pain is occurring as that stone is attempting to pass. Sometimes that pain that a person gets in the back will kind of radiate to the groin area, and that as a stone is moving. INO should be measured when somebody has your kidney stone, observing for signs of pus in the urine or blood in the urine or the actual stone. So depending upon the effect on the kidney or urine output, you may end up needing immediate intervention so that you don't lose kidney function. So with acute pain, we're going to assess the location, duration, severity. We are going to encourage fluids, administer pain meds, apply heat to ambulate the person if they're able to help pass the stone, and strain all urine. So for risk for infection, watch for vital signs, change in status, increase fever, chills, and signs of a urinary tract infection, which would show in the urinalysis of cloudy urine, a foul-smelling urine, or blood in the urine. So amount, odor, encourage intake as well to flush the bacteria. For deficient knowledge, it's always what do they know? So if they've had them before, that means maybe that they aren't following the diet to prevent recurrence. If there's a family history, that they know that there's an increased incidence if there is a family history. Sedentary lifestyle can contribute, so evaluate and educate about that influence. Do they have baseline knowledge of treatment, and are they aware of the importance of encouraging fluids? So some clients with recurrent kidney stones will require medications to prevent the recurrence. So are they comfortable with that information? If there's an infection, of course, that they take all meds as prescribed, but it could be if somebody has recurrent infections that they're increased risk for renal calculi. So avoiding a urinary tract infection can help with that as well. Person needs to know that they need to report worsening signs, infection, pain that's not relieved, foul-smelling urine, fever, chills, etc. So nursing care, the person is going to strain all urine, collect the stone that came out for evaluation, monitor signs and symptoms for worsening, watch INO, manage pain, encourage fluids, 2 to 3 liters a 24-hour period. It might require IV therapy, and then teaching, as we just described, about meds, preventing reoccurrence, etc. Hydronephrosis is when there's an obstruction in the urinary tract and urine refluxes back, and you have enlargement of the renal pelvis. So it could happen pretty quickly, but is treatable. So you have to treat the cause. If it's a stone, remove the stone. If it's a stricture, correct the stricture. If it's a mass, remove the mass. It can be somebody that has benign prostatic hypertrophy might have increased risk for hydronephrosis. Because the pelvis generally only can hold 5 to 8 mLs of urine, when there's obstruction, that can quickly enlarge that pelvis. So you have on the next picture, you see that there's a dilation of the ureters and a decrease in forward flow of urine and backflow. And so instead of the kidney having the cortex and medulla, you just have this kidney that's filled with urine, and there's a decreased function in the kidney. Signs and symptoms of hydronephrosis can occur gradually, and if that's the case, you might not have any symptoms, but it could be urinary tract infection because of the obstruction. As the disease gets worse, you'll have the flank and back pain, and which can, the hydronephrosis can lead to chronic kidney disease, which we'll talk about in a bit. Therapeutic interventions include treating the cause, removing the obstruction. So it could be, a tumor, the stones, or whatever. A urinary catheter may be placed and remove the obstruction. Long-term correction can be, like we mentioned, correcting the enlarged prostate, or removing the tumor or stones, or correcting the stricture. So if the tumor's too big or the stone is too large, and you can't reverse this hydronephrosis, it can contribute to death. Or there can be stents placed inside the ureters to keep them open, and a nephrostomy tube may be put in directly into the kidney to drain urine from there. So a nephrostomy tube will come out through the flank area, and we measure the intake and output. We want to see how much the nephrostomy tube is putting out, and be careful that there's no kinking of that tube or clamping of the tube. That would just only worsen this situation. The next disorder we're going to talk about is the cancer of the bladder. It's a common urinary tract cancer. It's more common in men than women, and occurs most often in people ages 50 to 70 years old. There is a direct correlation to exposure to industrial pollution or chemicals through work, or smoking. Big correlation. So there's an increasing incidence in America of bladder cancers. So it may occur just in the inner wall of the bladder, and sometimes will extend through the rest of the wall of the bladder, requiring removal, to do bladder removal. So if it's only in the inner lining, more superficial, it is treatment's a little bit different than when it has gone through the muscle wall. And sites where it can metastasize to include the liver, bones, and lung. So early signs of bladder cancer may be blood in the urine is no pain, but later on in the cancer can include pelvic pain, lower back pain, difficulty or painful urination, and inability to avoid. And it's often that the bleeding that gets somebody to get seen. So changes in bladder habits should also be noted. Diagnosis is done by assessing urinalysis. For telomerase, it's an enzyme that is pretty accurate in detecting bladder cancer early as well as late. Looking at urine for cells, cancer cells, performing culture, biopsying tissue through a cystoscopy up into the bladder or through the urethra, and IVP all can help with diagnoses. Interventions for cancer include chemotherapy. When it's a superficial, just on the inner lining of the bladder, BCG may be used where it's instilled into the bladder and to prevent recurrent cells. Laser, it may require removal of the bladder and urinary diversions. So we'll talk about the urinary diversions where it could be an incontinent urinary diversion where they'll take a piece of the ileum and have it exit out to the wall of the abdomen. And that a picture of that actually can be found on 848 on the top is an ileal conduit where the stoma opens to the outside, and somebody that has an ileal conduit needs to wear they're going to be constantly draining urine, and because it's ileum, it's also going to be mucousy, so they're constantly be wearing a bag. Versus the middle picture is a continent type of urinary diversion where a catheter can be inserted every couple hours into this pouch that's formed from the ileum to drain urine out. The difference in A to B is that A, there's no collection, it just is constantly draining. And in C is a different type of urinary diversion where the cecum forms a pouch, and the ureters from the kidney are inserted into this pouch, which exits out into the abdominal wall. Different type of continent diversion. So nursing care includes the use of a woundostomy continence nurse, a specialty type of nurse. Monitor urinary output, education about care of the stoma, care of the skin, care of how to apply the bags, and preoperative and postoperative care. There is a box on 848 about caring for a person with an ileal conduit, similar to doing colostomy care that you've done. Use of support groups may be helpful as well to understand that other people have gone through it, and anytime you have a change in normal function, and there could be body image issues because now they're needing to wear a pouch perhaps. Cancer of the kidney, rare at certain ages. Under the age of 45 it's considered rare, but not uncommon when age increases over 55 or so, just like most cancers, the older you are. Risk factors involved in cancer of the kidney include smoking, obesity, hypertension, somebody that's received dialysis long-term, radiation exposure, asbestos, and industrialized pollution. One of the issues with kidney cancer is often when it's found, it's pretty advanced. If it's metastasized, as we know, if it's increased in stage 4, it's spread further and can be considered terminal, and it's much more difficult to treat. Early signs are few. Later signs include hematuria, a dull pain in the flank area, and a potential palpable mass. Some other symptoms that may be associated with cancer of the kidney, but it can also be associated with other things, include night sweats, weight loss, fever, swelling in the legs, polycythemia, fatigue, anorexia, constipation. So all of those can be from other things, but if you put the whole puzzle together, sometimes it's leading you towards kidney cancer. So it could be a delay also when these earlier non-specific symptoms are seen. Symptoms that this cancer has spread include that weight loss, cough, bone fractures, liver abnormalities, and increasing weakness. And kind of because of the spread, it's evident in other parts of the body. So diagnosis of kidney cancer includes an IVP, cystoscopy, pyelogram, ultrasound, CAT scans, MRIs, and ultimately a renal biopsy. And we discussed the nursing interventions for renal biopsy in the previous lecture. They're going to be in a prone position, watch for bleeding. So therapeutic interventions include the removal of the entire kidney, which is a radical nephrectomy, including other lymph nodes in that area and the adrenal gland. You could also have nephron sparing surgery, which attempts to keep the function of the kidney by just removing the mass. And as with other cancers, can include radiation and chemo as well as immunotherapy. Nursing care after a surgical procedure after a nephrectomy is to watch for bleeding, monitor INO, and watch for any changes in urine output, assess for changes in respiratory status. As a result of the surgery, a pneumothorax, either from the surgery itself or spontaneous, may occur. Renal trauma from motor vehicle accidents or falls or sports injuries or something, and you'll see obtaining the history, what happened. Could be somebody's helmet went into my back, and that could be the cause. So looking for symmetry on assessment. Flank pain may be present as well as hematuria, blood in the urine. Diagnostic tests, you can do urinalysis, IVP, CAT scan, MRI, any of those imaging. And treat the injury. May require bed rest and may require, in some cases, surgical intervention. So watching the INO, vital signs, watching for shifts of vital signs, because if you have the drop, you know, of blood pressure and rise of pulse, you know you could be looking at a hemorrhage. IV fluids, pain control are all interventions. There are cases where the bladder, trauma to the bladder may occur when somebody's had pelvic fractures, hip fractures. And so the top part of the bladder may actually rupture, and urine enters into the peritoneal cavity. So that would be surgery may be necessary to repair that, and urinary catheter drain the urine. Polycystic kidney disease is when it's a hereditary disease, genetic disorder passed along, where there's cysts that can be fluid-filled blood, and they actually end up taking the place of the functional parts of the kidney, so you can have decreased kidney function. Signs and symptoms is a dull heaviness in that flank or back, hematuria, hypertension, urinary tract infection. A relationship between people with polycystic kidney disease and diverticulosis, which is interesting, as well as cerebral aneurysms. Increase in blood pressure, increase in a headache like no other would be a cause for extreme concern. There is currently no treatment. It's progressive. A person may end up needing a transplant. Diabetic nephropathy. Diabetic nephropathy is a chronic renal disease related to long-term complications of diabetes, type 1 or 2. It's the most common cause of chronic kidney disease. You have atherosclerotic changes in blood flow to the kidney. And I want to bring your attention to page 850. The pathophysiology is quite interesting. If you look at the second paragraph, please, initially patients lose only a small amount of protein in their urine. Remember, protein in the urine, there should be negative. This disease, protein in the small amounts of protein in the urine is called microalbuminuria. And this disease is detected only with careful watching by the healthcare provider. Frequent examinations of the urine. As the disease progresses, high output chronic kidney disease or non-oliguria can develop, in which large amounts of diluted urine is excreted without the usual waste products dissolved in it. The patient can lose large amounts of protein in the urine and develop what's called nephrotic syndrome, which we'll talk about. And nephrotic syndrome causes massive edema because the protein has left the blood, and it's the albumin that actually keeps fluid in the vessels. So loss of the albumin is going to cause the massive edema. So as kidney function decreases, the patient will require smaller dosages of insulin, because the kidney normally breaks down the insulin. And because it's no longer able to break it down, the person's going to require smaller doses. It'll last longer. So symptoms of diabetic nephropathy is that microalbuminuria, which is small amounts of albumin advancing to larger amounts of protein in the urine, proteinuria. Hypertension can complicate things, make things worse. As it progresses, you see decrease in urine output, increased toxic waste in the blood, and development of chronic kidney disease. Complications include because of chronic kidney disease, they may also, the problem with somebody with diabetic nephropathy is the damage to the kidney, as well as the cause of the damage to the kidney is because of the diabetes, and so there could be problems related to both of them and its relationship with cardiovascular disease. Therapy. Early on, we want to make sure we're controlling blood glucose to be normal glycemic as possible, as well as blood pressure. And the person will be on a lower restricted protein diet. There are supplements that, like a boost, that are for somebody with kidney disease, and they'll have a decrease in the protein. Later on, a person may require a dialysis or be on the list for a kidney transplant because of the decrease in kidney function. So our nursing care includes in education on the importance of controlling blood glucose, as well as blood pressure control, to prevent worsening of the condition, the disease of the kidney, from diabetes. So nephrotic syndrome we talked about a little bit, where there's loss of protein from the bloodstream into the urine, and as a result you have a change in capillary permeability and fluid loss. So in a case of the kidney, of increased glomerular membrane permeability. So nephrotic syndrome, you'll see greater than 3.5 grams of protein in the urine in a day. So with less protein in the urine, you'll see a shift in fluids. So you'll see edema or generalized edema called anasarca. As a result of the loss of proteins, the liver will try to make up for it by producing lipoproteins. And so then all lipid levels in the blood are going to rise. And then urine from the increase in lipoproteins. I'm sorry, I thought I lost it for the fourth time. The increase in lipoproteins, the urine output looks frothy, which is an interesting increased protein, increased frothy urine. So treatment is related to the cause, and sodium may be restricted because of the edema. Depending upon how much protein is lost will determine how much protein restriction there may be. Lipid lowering agents may be used, so your statins, anticoagulants to prevent clotting. So changes in the immune system can result from nephrotic syndrome, as well as coagulation, and that's why you have the addition of anticoagulants. So our nursing care, we're going to be checking daily weights, assessing abdominal girth for ascites, measuring I&O, and protecting skin when somebody has edema. That's going to be a nephrosclerosis is when there's scarring, hardening of the kidneys, hardening of the arteries, and therefore damage of the kidneys due to those changes. So interventions are related to trying to decrease the pressure because of the decrease in blood flow to the kidney. So you have let me back up a minute. Sorry about that. Okay, we'll start that again. So as a result of hypertension, you see the kidneys, the vessels in the kidneys undergo sclerotic changes, hardening, stiffening, and that could ultimately reduce blood flow and function of the kidney. As a result of those changes in some vessels, whatever is left, there'll be vasodilation to increase flow to the glomerulus, and as a result, increased pressure. So then that causes problems in the smaller vessels as well, and you could have ultimately big areas of the kidney that are damaged. So symptoms include seeing protein in the urine, hyaline casts in the urine, and symptoms of chronic kidney disease. Treatment is to reduce the blood pressure. Antihypertensives will be in use, and they may be pretty potent ones. Low sodium diet and dialysis may be necessary. Prognosis is poor. Only because if they have nephrosclerosis, they have arteriosclerosis or atherosclerosis throughout the body. So they're at increased risk for problems in the vessels in the brain, like a stroke or coronary arteries, heart attack. So nursing, diagnosis, ineffective health maintenance. The priority is to teach a person about what's necessary and why it's important to get that blood pressure down. And symptoms of worsening condition, like chronic kidney disease symptoms, would be something that is taught. Glomerulonephritis, inflammation of the glomerulus, causing the glomerulus to become more porous and therefore leaking the very things that would never go through the pores into urine, proteins, white blood cells, red blood cells. There's a relationship between glomerulonephritis and a previous strep infection. Strep throat, impetigo are big culprits, and what happens is there's antibody antigen deposits in the basement membrane of the glomerulus, which is what damages the glomerulus and allows for those cells to leak into urine, go into the tubule and into the urine. So causes, it can be that post-strep, so skin or strep throat. Good pastures syndrome is an autoimmune response where there's the body goes after the basement membrane. Chronic glomerulonephritis, when somebody has years of inflammatory disease, protein protein in the urine, hematuria, are maybe present, and you see it with lupus or type 1 diabetes or diabetes dependent on insulin. Often found because of some other reason. So symptoms include oliguria or decreased urine formation, hypertension, electrolyte imbalances, edema, and flank pain. So periorbital edema would be what's seen first, so around the eye, edema found around the eye, as well as ascites in the abdomen, in the lungs, pleural effusion, and in the extremities. Changes in color of the urine may be darker, may show protein in the urine and be foamy and have the red blood cells, white blood cells, albumin, CAS, etc. Ultrasound may be done, X-ray, and biopsy for glomerulonephritis. So it can resolve on its own, and you see it with children acutely obtained. They'll be recover without any difficulty. Adults may recover, or else they may also progress to a chronic glomerulonephritis. Acute kidney injury may result. And with chronic, it may lead to chronic kidney disease, which we'll talk about. So diagnosis occurs with the urinalysis, as mentioned. Therapeutic measures are going to include treatment for chronic kidney disease if that's present. Otherwise, it normally just resolves. If treatment's going to be for symptoms, so sodium and fluid restrictions may be used, medications for hypertension, and antibiotics for any strep infection. If a person has extreme fluid overload, they may need to be on dialysis. So we're going to encourage rest, edema with a fluid, sodium, and protein restrictions may treat the edema, teaching a person about preventing glomerulonephritis or treatment of any strep infection, impetigo or a strep throat perhaps, and monitor the kidney function with BUN and creatinine. Acute kidney injury is our next topic. We're going to talk about acute kidney injury as well as chronic kidney disease. So it's when there's a decrease in the function of the kidneys, and it could be a chronic condition or acute. In the case of AKI, it's in sudden loss of kidneys function. So remember, the kidney's function is to get rid of waste products. So what you're going to see is the accumulation of waste products in the blood, or decrease in the ability to make urine. And with acute kidney injury, a person may, if it's found early and treated appropriately, will recover. But sometimes people go from acute kidney injury and go into chronic kidney disease. You want to note urine output, and causes of acute kidney injury can be from hypotension, dehydration, obstruction, glomerular disease, tubular necrosis when the renal tubules are damaged. And it could be from that diagnostic contrast. So if somebody is using induced contrast for imaging, it can damage the kidney. And we talked about that earlier. So when we talk about acute kidney injury, we will talk about its causes being pre-renal, intrarenal, or post-renal. And remembering that it's in relationship to, did the cause come from before it got to the kidney, or inside the kidney, or outside of the kidney? So pre-renal often is related to a decrease in blood supply to the kidneys. It's a common cause of acute kidney injury. So decreased blood pressure or the blood loss, hemorrhaging, a shock, or a trauma may be contributing factors for pre-renal acute kidney injury. So there's a decrease in blood flow to the kidneys, therefore to the nephron, therefore a decreased ability for its to do its job. So evaluating possible causes. So if it's dehydration, give IV fluids. If it's a block in blood flow to the kidneys, say the renal arteries, they may put a stent in to increase blood flow. Get the picture here. Intrarenal failure is when there is damage to the kidney itself, to the nephrons. So it could be a result of decreased blood flow, ischemia, could be from toxins, infectious process or something that causes damage to the kidney, allergic reactions, and severe muscle injury like rhabdomyolysis can cause damage to the nephron. Post or any of the nephrotoxic medications. So you'll see again contrast-induced nephropathy described on page 854. And we talked about that already, that you need to assess for risk factors prior to administering contrast when imaging is done, CAT scans or IVPs. So post-renal failure is after the kidney, and it's often related to an obstruction. So if blood flows to the kidney and is filtered and urine is made, and then it gets to the ureter and there's a block in the ureter. So it could be that there's a kidney stone, or it could be a tumor, mass of some sort, or a mass in the bladder or the urethra that blocks the flow of urine. So those are contributing factors to acute kidney injury. So those nephrotoxins that were mentioned that can damage the kidney, the aminoglycosides, and contrast dyes, and certain chemicals can be damaging to the kidney. So prevention can include those protocols for contrast-induced nephropathy, assessing for allergy, hydration, and for assessing serum creatinine clearance prior to giving either contrast or any of the nephrotoxic medications. Peak and trough levels of your nephrotoxic antibiotics are performed. And this is all to prevent acute kidney injury. So to go back now, we're going to talk about the phases of acute kidney injury: oliguric, diuretic, and recovery, listed on page 853. So oliguric phase, you have a decrease in urine production, less than 400 mLs in a 24-hour period. And remember, normal is 1,000 to 2,000, so that's a significant decrease. So most people, or 50% of those that have acute kidney injury, will experience this phase within the first 24 hours to 7 days. And it can last for a couple of weeks up to several months. The longer they're in this phase, the worse the outcome. So in this phase, you have retention of fluid, electrolytes are imbalanced, and you can have some acid-base imbalances. So in the diuretic phase is the second phase, where the kidneys start to come around and excrete waste products again, and an increase in urine output, 1 to 3 liters. Normal 1 to 2 liters, then you have an increase in urine being produced. So you have osmotic diuresis, where there's movement of water because you now have all this elevation in waste products, so a higher concentration. So the water is trying to help get rid of it. So the kidneys are unable to concentrate urine, so now you have the other end. You have dehydration and hypotension are a concern. So the nurse watches for all of that, hypokalemia, hyponatremia, as well as the hypotension and hypovolemia. So keeping an eye on your renal function testing, BUN and creatinine, and the phase lasts for 1 to 3 weeks. In the recovery phase, the last phase, you see the glomerular filtration rate going up. Remember, in acute kidney injury, the kidney is not doing what its intention is. So waste product levels will decrease. BUN and creatinine will go down, and but the recovery phase may last up to a year. So those that are older may not fully recover total kidney function, and then exhibit symptoms of chronic kidney disease. Therapeutic interventions for acute kidney injury is to treat the cause. You want to prevent permanent damage or chronic kidney disease. So supportive treatment, treat the symptoms as they develop. Keep an eye on fluid and electrolyte balance. Dialysis may be necessary, as well as continuous renal replacement therapy, used short-term to filter blood. Continuous renal replacement therapy removes fluid along with hemodialysis. Some people will not be able to tolerate hemodialysis, so it's an alternative. And blood flows through a filter, and fluids and solutes will move into a collection bag. Okay. Chronic kidney disease is over time. There's a gradual decrease in kidney function, and it's progressive and irreversible. Whereas acute kidney injury can be, in most cases, reversible, with some leading to chronic kidney disease, or as we'll describe. There are a significant relationship with chronic kidney disease as a leading cause of death. And you see decreased kidney function over time, and therefore, as a result, you have the buildup of waste products. And you see the effects of chronic kidney disease on every body system. So some contributing factors include diabetic nephropathy, nephrosclerosis, glomerulonephritis, and autoimmune diseases, which we hinted at already. Pathophysiology: as a result of the cause, you have a large proportion of the nephrons damaged. We call renal insufficiency when you have 75% of nephrons lost, and end stage renal disease or kidney disease is when 90% of nephrons lost. So imagine with renal insufficiency, only 25% are functioning, and in end stage, only 10% of nephrons are functioning. You have a serious decrease in the ability of the kidneys to do their job. In an early stage, a person may have no symptoms at all, even though they might have a significant loss of half of their function of their nephrons. Signs and symptoms of chronic kidney disease include accumulation of fluids, electrolyte imbalances. You see the BUN and creatinine elevated, acid-base imbalances, and anemia, because think about kidney function includes erythropoietin, formation of red blood cells. So all of this is affected. This picture on this slide, actually, I love these because it shows how and no system stands on its own, and you have this body systems wide effects from chronic kidney disease. If you look on page 856, it goes into more detail on the effects of chronic kidney disease on body systems. But I'd like to bring your attention to the stages of chronic kidney disease as listed on that same page at the top. So in stage 1, chronic kidney disease, you have a GFR of greater or equal to 90 milliliters per minute. And in stage 2, 60 to 89. But if you go to stage 4, you have a glomerular filtration rate of 15 to 29 milliliters per minute. If you remember what it was, 100 to 125, that's a significant decrease. And somebody is going to require dialysis when they have a decrease in GFR when it's less than 15 milliliters per minute, and require a transplant. And often somebody will be receiving dialysis and on that transplant list, and often people won't survive long enough to get a transplant. But on this page you have all the effects of chronic kidney disease on all the different body systems. Okay, for a minute I'm going to just talk about some of the electrolyte disturbances. You have hypernatremia as a result of the kidneys not able to balance out sodium, which causes then edema as well as hypertension. Hyponatremia may occur when too much sodium is lost, when a person has vomited or diarrhea, or when somebody's urinating large amounts of urine. So hyperkalemia is another one where you can, hyperkalemia is over 5 and life-threatening over 7. Remember, dysrhythmias and cardiac arrest when you think of hyperkalemia. So somebody should report muscle weakness, abdominal cramping, and diarrhea, whose changes in mental status should also be noted by um, the nursing staff. Anybody that has hyperkalemia is going to be monitored on a cardiac monitor. So lab values are assessed, and IV insulin with glucose or calcium gluconate may be used to reduce that high potassium, because it's going to push the IV insulin with glucose is going to push the potassium into the cells. And you also see out of the bloodstream, and you also see K-oxalate given to eliminate potassium in the stool. So in addition to those measures, a person may require dialysis to get rid of that potassium. So a person with hyperkalemia should be avoiding those foods that are high in potassium. Another imbalance is with calcium, and there'll be low levels of calcium because of decreased vitamin D, so therefore decreased calcium absorption. So when you have a below 8.5, hypocalcemia, and remember that when calcium is low, phosphorus is high. So that is, to get that in balance, there'll be binders, calcium and phosphorus binders taken for people that have high phosphate. So chronic kidney disease therapeutic intervention includes high diet, usually restricted protein, unless they're receiving dialysis, because when somebody's on dialysis, they lose protein. So it depends. Normally a kidney diet is low protein. They'll also be on a low sodium, low potassium, and low phosphorus diet, increased calcium, as we saw. Hypocalcemia is a problem with people with chronic kidney disease. They will be supplementing some vitamins and minerals, such as iron, folic acid, etc. They'll be on a fluid restriction because of inability to monitor fluid balance. So a diet is discussed, but medications, they might be on diuretics, antihypertensive, phosphate binders, vitamin D and calcium, and K-oxalate for the elevated K. Dialysis for fluid overload, hyperkalemia, uremia, and neurologic signs. Dialysis may be performed. And this slide shows a picture of hemodialysis where a machine is actually functioning as the kidney. And remember, somebody with a low GFR is going to require the hemodialysis to perform the functions that the kidney would have. So that's including fluid balance, as well as getting rid of waste products. Good description of how hemodialysis works is on page 859. Somebody getting hemodialysis is going to get treatments a few times a week, usually 3 or 4 times a week, and it could take a few hours. Dialysis centers are usually open, 24 hours, and try to accommodate the person because there's people that go to work after treatment. So these people on this picture and the next are lying in a bed, but you'll often, the second one's in a chair, but you'll often see people in like recliner chairs all around a room getting their hemodialysis done. Some of the issues that we need to be aware of is post-hemodialysis is the person may often, after treatment, feel weak and tired and experience hypotension and cardiac dysrhythmias and potentially even angina. So fluid and electrolyte levels will drop rapidly and can cause the person to feel lethargic and even have muscle cramps due to electrolyte changes. Heparin is given to keep the blood from clotting as it's passing through the machine. So bleeding at the access site, it needs to be monitored as well as from the nose or somewhere else if there was an injury. So the vascular access sites are shown in the picture on the bottom of 860, where you can have a AV fistula or a AV graft in the lower picture. So an AV fistula is the gold standard, and it's placed in the arm when possible. You will have a nephrologist for assessing that access to make sure that it is fully developed and available to undergo dialysis. So if somebody's a newly provided fistula or graft, dialysis will have to be performed through another site. So it might be through a central catheter until the AV fistula or graft is what we call matured. So the fistula is when the artery and vein are sewed together under the skin, and an AV graft is an artificial tube connects the artery and vein together. And so the needles necessary for dialysis are inserted into the graft or fistula. So we need to assess the access for patency. It's normal to feel a thrill or hear a bruit at the site. If you have no bruit or thrill, that means there's a block there. The healthcare provider needs to be notified immediately. And it's important that we're checking this because the person that has these access sites needs hemodialysis. They're in chronic kidney disease, and they have no other way of managing the waste products. So they're going to need an alternative site in order to get hemodialysis. So as soon as we determine that there's a problem, there is treatment that can be done. Otherwise, I would have to do a revision of the access, and then that delays for maturity, et cetera, and use. So there's a block on page 861 that talks about how do you care for a person that has a fistula or a graft. And post-operatively, when they're getting a graft or fistula, to assess neurovascularly, the extremity will be elevated, pulses will be assessed. We're looking for that bruit or thrill. Dressings are checked for bleeding. Assessing for pain, because if it's severe, it could be telling you a complication. It's important that blood pressures and IV access is not done in the arm that has the AV fistula or graft. And the patient needs to know, as well as staff, where the graft is. So this is just a picture of the two. This is the fistula where the artery and the vein are connected, and this is the connection between artery and vein via a separate tube that connects them. So for some peritoneal dialysis, description on 861 and a picture on the next slide where the peritoneal membrane is used as the filter. for removing waste products and fluids. There's a catheter that's inserted into the abdomen, into the peritoneum, and the dialysate is instilled into that peritoneal cavity. And so you fill, it stays in there, it dwells, and then it drains out. And I'll show you this picture next, where you have a catheter into the abdomen. This is the dialysate. It goes in, it stays in, and then gravity will drain that out. So over time. So some people do that throughout the day. Sometimes it's attached to a machine and can be done at night. The dialysate, you need to make sure it's everybody. What's in there is going to be determined by lab values and stuff, and family and the patient needs to know, all the ins and outs. This is usually a nephrology nurse will go out and work with the family and the patient multiple times for possibly even weeks at a time to make sure that they understand the process, because this is a person doing it on their own without a healthcare provider. Complications include, because as a result of poor technique, you could have peritonitis, and peritonitis is can be very serious and even life-threatening. So family members need to be aware of that complication. And last but not least, we'll talk about kidney transplant. The intervention related to chronic kidney disease, decreased kidney function, and dialysis may keep them alive until transplant can be performed. It can be a living related donor or a cadaver donor, or even can be a living donor not related, and you'll hear about those big domino transplants where I'm willing to give somebody my kidney, but I'm not a match, but I'm a match for somebody else, so I could give it to them. A person that has a kidney transplant is going to require anti-rejection drugs. So here's the diseased kidneys are kept in there. The transplanted kidney goes into the abdomen. Interesting. Look at that going. Blood is filtered, popped off of the iliac artery, and then the ureter is transplanted into the bladder this way. Interesting. The diseased kidneys are kept. Nursing diagnoses for somebody with kidney transplant or chronic kidney disease starts on page 864 and 865. So let's go to activity intolerance first, related to anemia. Because of erythropoietin problem, so somebody might get erythropoietin or epigen needed, or transfusions, but we're going to be watching the hemoglobin and hematocrit, assessing skin color, mucous membranes, shortness of breath, chest pain can all be a result of anemia, and encourage rest periods. Risk for injury related to bleeding and platelet dysfunction, and when somebody's on dialysis, they're receiving heparin. So we're observing for signs and symptoms of bleeding in the stool, in the vomit, in easy bruising, easy bleeding, puncture sites that we can't get to stop bleeding, and then our vital sign changes we need to be observant for. When possible, have an alternative way of administering meds versus by injection. Increased risk for infection because the immune system is affected. Temperature might be within normal limits, and we want the temperature and white blood cells to be within normal limits. So we're watching for signs and symptoms of infection. We are choosing roommates carefully, encouraging people that are sick to not be around somebody. Think about people that have had transplants and they're on immunosuppressants. So maintain skin integrity, especially those that have edema, because skin can break down and we want to avoid infection through the skin and sepsis that way. Hand hygiene, any site of infection should be cultured. Patients that have immune suppression are at increased risk for influenza and pneumonia, but vaccines, as we know, are sometimes not recommended. So that should be reviewed with the healthcare provider. And family members should also be aware of signs and symptoms so that the person gets treated appropriately. Impaired nutrition, we want to make sure that they're able to maintain appropriate serum, protein, and albumin levels. Low protein diet, and that could be tricky because we're meat eaters here in the U.S. So we want to decrease the amount of those waste products if our kidneys have difficulty eliminating it. Calorie count to assess whether the diet intake is appropriate. Oral care can help with improving appetite when somebody has anorexia. May need the small frequent meals, dietary supplements, and medications for nausea may be necessary prior to meals. This is all to maintain proper nutritional intake. So your excess fluid volume, monitor weight INO, fluid restrictions, monitor for fluid retention. Electrolyte imbalances, watching those labs, dietary restrictions, sodium, potassium, as we talked about, and watch for dysrhythmias with the abnormalities in K. Waste products, watch oral care and skin care, protect from injury, protect from infection. We talked about those. So I think I have it. I am definitely going to save here and hope this is helpful. The rest of this slide presentation is review questions.